Good morning, and thank you for that very kind and generous introduction. It's a great honor and pleasure to be at Texas Heart Institute, and it's also giving me a profound sense of deja vu. Being a medical student at Baylor, I did my fourth year cardiology rotation on the Hall and Garcia Cardiology Consult service here. And to tell you how long ago that was, every Wednesday on that service, we would work up a plane load of Dutch patients who were flown from the Netherlands to have bypass surgery here by Dr. Cooley and his group, because there was no cardiac surgery program at that time in the entire country of the Netherlands. So that was a long time ago, but the memories of it remain crisp, and I learned my reverence for clinical auscultation and the physical exam from Dr. Hall specifically. So without further ado, we'll get into this talk, which is not meant to be a negative about any procedure or approach to patients with stable angina, but rather a proposal for you to consider a new paradigm when you integrate all of the available clinical evidence and physiology. So the objectives today are to review the historical origins of the current stable angina paradigm, to discuss some of the inconsistencies and shortcomings with this paradigm, and as I mentioned, to propose to you a vastly simplified, integrated, and physiology and evidence-based approach to patients with stable angina, which would be a paradigm shift compared to how we currently treat most patients who come to see us with stable angina. So I'm going to give a little bit more background, and then I don't know if it's something that happens to us as we get older, but I've become much more interested in medical history. So I'm going to give you a little bit more historical background of the development of the current paradigm, present to you some evidence-based challenges to the paradigm, and again, offer you my approach, which I feel is a very simplified but evidence-based approach to patients with stable angina. So most grand round speakers speak about very rare and esoteric diseases, and we come to listen to them because we don't see many of those patients in our daily practice. Well, this is not one of those grand rounds. Stable angina is a very common and prevalent disease. In this data from the NHANES study, you can see that about 4% of adults over age 20, or 11 million adults, have stable angina at any one time in the United States. And the outpatient costs, which are mostly limited to testing, which we will get into how relevant the testing is, cost $21 billion in 2016. Now, our 21st century stable angina paradigm is really based on 20th century observations and science. And it basically postulates the following: that somebody that has obstructive CAD, the so-called rusty pipe paradigm, who develops ischemia and angina, will ultimately develop an MI and will ultimately die, and that process can be interrupted by relieving this obstruction either by bypass surgery or percutaneous coronary intervention. And just to point out that this is sort of a mainstream point of view, this is a paper published in JACC in 2012 from the cardiologists from Belgium who were the pioneers of fractional flow reserve. And I will just read this quote to you. They said in their paper, "It is important to emphasize that in coronary artery disease, the most important factor related to outcome is the presence and extent of inducible ischemia. A functionally significant stenosis, right, obstructive CAD, generally causes anginal symptoms and is associated with impaired outcome. Therefore, functionally significant stenosis should be revascularized if technically possible." Now, some of you may be seeing the citation at the bottom and saying, well, this is 2012. That was 11 years ago. We've certainly moved beyond that in 2023. Well, not so much. So this is a slide from the 2021 AHA-ACC guidelines for the evaluation and diagnosis of chest pain. And you can see that this algorithm is for patients with stable chest pain and no known CAD. So patients that we see in our office every day. I saw 2 patients like this in my clinic yesterday before I left to come to Houston. And this is the algorithm, and I don't want you to worry about reading the algorithm, but the blue arrows are all the spots in the algorithm where we make a point of defining the coronary anatomy, that is, finding coronary obstructive disease. The red arrows are all the points in the algorithm where we evaluate patients for coronary or myocardial ischemia. So even though the quote from Jack was 2012, this approach of identifying and intervening upon obstructive disease or ischemia providing disease takes a central role in our most recent chest pain guidelines. So if we think about what we want out of an approach to stable angina, we want to obviously improve the quantity of life. That is, we want to prevent death, and we want to improve the quality of life, which in most patients with angina means relieving that angina, eliminating that angina. And the desired attributes of a paradigm that guides an approach to a large group of patients is that it should apply to the broadest possible spectrum of patients, should be based upon contemporary understanding of pathophysiology and supported by robust data from randomized clinical trials whenever possible, and should spend as little of society's money as possible as well. So let's get into the history a little bit. So early in the 20th century, 2 technologies that started out being developed entirely separately became intertwined in the latter 2/3 of the 20th century. And specifically, I'm talking about stress testing and coronary angiography. So this is a slide from paper in Lancet from 1918, so a 105-year-old slide, but it's historic because it is the first slide that demonstrates ischemic EKG changes in somebody that has the acute onset of chest pain in a doctor's office while he was preparing to do an EKG. So you see the top panel, chest pain present, ST elevations present with T-wave inversions, and bottom panel, chest pain spontaneously resolved back to a normal looking single lead EKG. So it wasn't long after this observation that people started trying to provoke ischemia by various stressing modalities, most commonly exercise. And the original exercise stress test was not on a treadmill as we do today, but was just on a step like this, and you would have the patient step up and down, step up and down, step up and down until they got their heart rate up and they had EKG leads on, and you would see if they developed ischemia. So we've come a long way technologically since then. And then this is the first study that associated, and I use the term associated on purpose, the presence of an abnormal or an ischemic electrocardiogram with survival. So this is a paper published in 1967, as was normal at the time. Only male life insurance applicants were included, over 2,200 of them, who had undergone stress testing between 1949 and 1963. And you can see that patients with ischemic EKG changes on their stress test had a markedly reduced survival compared to patients without ischemic changes, and the patients without ischemic changes had the same survival as age-matched healthy controls. So, and you can find these same survival curves scattered throughout the next 50 years with every available stress testing modality, whether it's dobutamine echo or PET or thallium SPECT or MR perfusion. If you have an ischemic response on stress testing, it is, again, I'm using the term, associated with significant impairment in overall survival and an increase in all-cause or cardiovascular death. Okay, so we jump ahead to 1958. This is a slide from the 35 millimeter cine film of the first angiogram ever performed in Cleveland by the pediatric cardiologist Mason Sones. This was done by accident. At the time, it was thought that if you replace the blood in the coronary with contrast, the patient would fibrillate and die from lack of oxygen delivery for those few seconds. So he was actually trying to do a root injection with a catheter that just happened to slip into the ostium of the right coronary, injected what was then very highly ionic contrast material. The patient developed profound bradycardia from the contrast injection, to the point that the rumor has it that Sones was about to do open chest cardiac massage because there was no CPR in 1958. And as he was dousing the patient's chest with betadine, the patient woke up and said, "What the hell is going on here?" So not only did the patient survive, but that launched the era of diagnostic coronary angiography that quickly spread from Cleveland to the rest of the United States and around the world. And, you know, within 10 or 15 years, we started seeing studies like this, where again, remember, there was no intervention at that point, but we started seeing natural history studies like this study from University of Alabama, Birmingham, that was a big cardiac center at the time, that divided patients based on whether they had one vessel disease, no vessel disease, two vessel disease, or three vessel disease, and looked at survival over 50 months. And you can see that there is a gradient, that the more obstructive disease or the more vessels in which you have obstructive disease, the worse your survival. So again, this is an association between coronary obstructive disease and survival based on the number of vessels involved. And in 1974, now that we had the two technologies come together, it was found that when you stress test somebody and they have an abnormal stress test and you perform a coronary angiogram on them, lo and behold, they have obstructive coronary disease. And this paper from Circulation in 1974 shows the percent of patients that had abnormal ST changes. Again, it's somewhat as a proportion of the number of vessels diseased, but the authors wrote, the use of exercise stress testing has achieved wide popularity and can safely be performed in large numbers of people in the office, outpatient clinic, or hospital. And you know, sort of what they went on to say is that then will allow us to identify people for coronary angiography, and that then will allow us to figure out who has these obstructive lesions. Not that we could do much about it then, but times were changing. So by 1970, we had a simple, widely available method to detect ischemia and an invasive method to demonstrate obstructive epicardial coronary disease. And there was a very strong association between ischemia and mortality. There was a very strong association between ischemia and the presence of obstructive disease, and a very strong association between obstructive coronary disease and mortality. So those associations would lead anybody to think that if we could do something about the obstructive disease, we may be able to interrupt the cascade of bad things that happens afterwards. So that led to the birth of bypass surgery and the early origins of the ischemia revascularization paradigm, meaning that if we revascularize these obstructive lesions, we sort of bypass, no pun intended, the cascade of bad things that happens when you have angina, ischemia, that inevitably lead to increased mortality. So this is, one article's timeline of the birth of CABG. Needless to say, Texas Heart was right in the thick of this. DeBakey's contributions were dated to 64, but Saveston and Getz were a little bit before that. And I must give it to our surgical colleagues that the initial procedures were done in the early 60s. And by the 1970s, they had already performed 3 landmark randomized clinical trials to compare outcomes between bypass surgery and medical therapy. And those studies, which you probably all know, were the VA cooperative trial, the European Coronary Surgery Study, and the CAS study. And here's just a little bit of information about those RCTs of CABG versus rudimentary medical therapy. They were almost all male patients again, relatively small sample sizes by today's standards, less than 800 patients. 2 of the 3, CAS and VA cooperative, did not show a mortality benefit. There was a mortality benefit shown in the European study. And a subsequent meta-analysis of these 3 studies and some smaller studies, including one performed here at Texas Heart by, I think Matur was the first author, showed that there was when you meta-analyze all this data, that there was a statistically significant reduction in mortality from bypass surgery. Now, you'll recall that, I put on the title of the slide, that the medical therapy was rudimentary. And that really means beta blockers and nitrates, that's it. No statins, no ACE inhibitors, no dual antiplatelet therapies, et cetera. And there was early skepticism, and some people, including Eugene Braunwald, and a name that may not be familiar to you, Henry McIntosh, actually published editorials in circulation saying that, hey, let's put the brakes on here. We're overdoing this a bit. The data is not that robust. And interesting story, at the time that Henry McIntosh's editorial was published in circulation, he had been recruited to Baylor as the chair of medicine from Duke. And when he published that editorial, Dr. DeBakey promptly fired him, hired Tony Gatto, and McIntosh spent the rest of his career in a private practice in Florida. So I don't know what the lesson of that is, but if you speak truth to power, you could end up with a very nice life in Florida. So in the same time that those editorials were published, this poster was presented at the AHA. So this is meant to encourage any of you who feel dejected by your abstracts getting accepted as posters. This is Grunzik, you can see in this blurry picture that he actually has one of his early angioplasty catheters here, and he's presenting the first clinical data on balloon angioplasty in human beings as a poster. And it was hoped that first with balloon angioplasty and then with stenting and then with drug-eluting stenting, that percutaneous intervention would be a less invasive way to achieve the mortality benefits of CABG, even though from a functional standpoint, they do very different things. CABG bypasses bunches of both obstructive and non-obstructive plaque, whereas stenting, as you all know, treats focal lesions and leaves untreated lots of potentially vulnerable plaque that is not obstructive or physiologically significant. And unlike our surgical colleagues, it took interventional cardiology, of which I was one by this point, 20 years to do the first randomized trial, which was REDA-2, which was the first randomized trial powered for death and MI. Now, this was pre-statin and pre-stent, and you can see the cumulative incidence of adverse outcomes, meaning death or MI, was much higher in the PTCA arm than in the medical arm, and that's because of the instability of the coronary lesion after you do a balloon angioplasty, and a lot of these patients had abrupt vessel closure from dissection, had to be rushed off for emergency bypass surgery. Almost all of those had an MI, and a significant amount would die from that event. So moving into randomized trials in the OMT stent era, you all know these studies. First, there was Courage in 2007, then Barry 2D in 2009, FAME 2 in 2012, and more recently, the ischemia study was published. All of these, and with some variations, randomized patients to best medical therapy versus revascularization, with the ability of patients in the medical therapy arm to cross over for refractory symptoms or acute coronary syndromes. And just a quick word before we get into some of that data is, just want to make a pitch that when I say optimal medical therapy, which is the term coined by Bill Bowden in the Courage trial, it's more than just pills. I mean, it includes pills such as antiplatelet therapy and disease-modifying therapy, anti-ischemic therapy for symptomatic patients, but also includes things like a healthy diet. You can choose which diet you believe. There's not a lot of great data for diets out there, except I think for the Mediterranean diet. Regular exercise, cardiac rehab, if available, smoking cessation, blood pressure and glycemic control, and maintaining an optimal weight. So that's should be the baseline approach when we're starting somebody on optimal medical therapy. So the first goal of a stable angina paradigm I mentioned to you was to prolong life. And so the question is, does revascularization reduce mortality? Because you would certainly predict it would based on the paradigm and the associations between either ischemia or coronary obstructive disease and outcomes, including mortality. So this is a meta-analysis that I did with one of the residents, Andrea Suarez, who's now a cardiology fellow at UC Davis. We did this when we were in St. Louis at WashU. The studies you will recognize, but what's a little bit different about this meta-analysis is we asked the authors of all the studies to just give us data on the patients that had ischemia on stress tests at baseline. So either all these patients had ischemia, either because we got a subset of those patients from the authors, or for example, in FAME 2, everybody had an ischemia surrogate, meaning an abnormal FFR. So all of those patients are included, all of the ischemia and ischemia CKD patients are included because ischemia was required for enrollment. And you could not ask for a more neutral result in a meta-analysis of 11,500 patients with very tight confidence intervals of 0.86 to 1.08 than this. So it does not appear that PCI or CABG reduces death in patients with ischemia or with the surrogate for ischemia, meaning an abnormal FFR. So that's sort of one problem with the existing paradigm that needs to be dealt with. And it appears that the reason that revascularizing ischemia doesn't improve outcomes is because ischemia is not really the problem. Ischemia is a marker of the disease. So when you have a patient that has a single vessel, say mid-LAD, 90% stenosis, and you stent that, and that patient's prognosis doesn't improve, why is that? It's because they have tons of plaque that's either not even apparent angiographically or what we call minimal luminal irregularities, or they have 10, 20, 30, 40% plaque that we don't intervene upon. So the ischemic stress test is telling you the patient has an impaired prognosis, but that doesn't mean that ischemia is the cause of that. And if you look, this is data from Courage. If you look at patients divided by the amount of ischemia they had on stress testing as a function of freedom from death, MI, or an acute coronary syndrome, the three curves completely overlap. So there is no differentiation in outcomes based on the degree of ischemia. However, they came up with a scale to assess atherosclerotic burden based on the angiograms. And you can see that when you divide patients based on their atherosclerotic burden, the less burden you have, which is green, the better your event-free survival is. And the highest burden you have, which is red, you have almost a 40% reduction or a 40% incidence of events with a very highly significant p-value. So that's one of the problems about dealing with associations and acting on associations is that you can end up chasing a marker of disease rather than the disease itself. And fixing markers never made anybody feel better or live longer. It's like, treating somebody with heart failure, but your only goal is to lower their BNP to normal. And this is the same kind of analysis done in the ischemia trial. Again, when the patients are divided by ischemia severity, severe, moderate, there was no difference in outcomes. This is in the total cohort combined, both with and without revascularization. But when you divide patients based on their method of semi-quantification of atherosclerotic burden, you can see that the more coronary disease they have, the higher the event rate. And again, this is in both patients who got revascularized and didn't. And recall that the bottom line results of ischemia were that revascularization didn't improve outcomes. So you can have a situation that worsens your outcome, but that doesn't mean that an intervention is going to improve that outcome. And that can't be taken for granted. That has to be proven with clinical trials. So second objective of what we want to achieve with patients with stable angina is get rid of their angina. I mean, that's what patients want, right? So this is data that also I did with the same fellow or same resident in St. Louis. These are the Courage patients. This is from Courage data. Courage enrolled over 2,000 patients, but you can see the N here is only 1,784 because not all patients at study entry in Courage had angina. You could get into Courage if you just had an abnormal stress test done for whatever reason with no angina. So if you just take the patients with angina, there were 1,784 of them. So at time zero, right, 100% of them in both groups had angina. The red is the PCI group, the black is the OMT, right? So 100% have angina. 1 month later, 79% of the patients with that underwent PCI still have angina, and 90% of patients who are randomized to medical therapy still have angina. And you can then see over time that both of these numbers come down about the same. In fact, the incremental benefit of PCI drops from 11% here, 13% here, 11% here at 3 years to just 5%. So what's going on here over time? I mean, you put in a stent, as you all know, the hemodynamic effect is immediate. So why are people developing less angina over time, over 3 years? And this is from ischemia, looking at it at the probability of being angina-free. Just focus on month 3. So blue line is the conservative treated patients. The red line is the invasive approach. And on the y-axis is the Seattle Angina Questionnaire score, with 100 being no angina, and then as the numbers get lower, you have more and more angina, to when the numbers get to 30, you're having angina every day. So you can see if patients are having minimal angina at 3 months, they get no benefit from revascularization, which is kind of obvious because they're not having many symptoms to begin with. But let's look at the patient with daily angina at 3 months. The percent that are angina-free in the invasive arm is 30%. So 70% of patients with daily angina continue to have some amount of angina in a study that mandated complete revascularization for the interventional approach. Now that number is much lower in the conservative arm, which is about 8%. But I don't think any of us tell our patients when we send them to a PCI to treat their angina that they're going to have a 70% likelihood that the angina is not going to go away. And in fact, one of the residents at USC, Aisha Singh, and I just looked at the same ischemia database, and specifically in the patients that underwent PCI, and we wanted to see how often patients who underwent PCI with complete revascularization being the goal were angina-free at both 6-week and 12-month time points. We didn't look at time points after that because we felt that if you had new angina at 3 years, that may well be a new lesion. But does anybody have any guess as to what percentage of the PCI-treated patients in ischemia were angina-free at both 6 weeks and 12 months? I'll tell you, it's not much different than this number. It's 34%. So 2/3 of patients who undergo PCI have persistent, albeit in some cases improved angina, but not angina elimination. And I don't have to remind you of the Orbita trial, which was the first sham-controlled trial of PCI, with a principal hypothesis that PCI will increase exercise time more than a sham procedure. The endpoint was time on a treadmill. The goal was to detect an increase of 30 seconds with 80% power and a standard deviation of 75 seconds. That required 200 randomized patients, 100 in each arm, which was exactly the size of the study. Now, that study has been often criticized for being quote unquote too small, but there's no such thing as too small. When you do a sample size analysis, you get a number and you achieve that number. It may be smaller than people are used to seeing, but there's no such thing as too small when the sample size is what the sample size calculation required. And here's just a summary of the Orbita results. Their endpoint was 6 weeks. Again, the study has been criticized that the 6-week endpoint is too short. But again, these are patients with single vessel disease. Why would you need more than 6 weeks time to improve exercise time after you take a lesion from an 80% obstructive lesion to no lesion? I mean, it should be immediate, right? So 6-week time point seems perfectly reasonable to me, but stent compared to sham at 6 weeks, there was no significant improvement in exercise time, time to 1 millimeter ST depression, peak oxygen update. The Seattle Angina Questionnaire scores about physical limitation, angina frequency, angina stability, quality of life, a European quality of life score, the Duke treadmill score, or the Canadian Cardiovascular Society angina grade. The only thing that improved was the dobutamine stress echo. So again, we treated a marker of a disease, right? We made the stress test better, but we didn't make the patient better. So shifting gears a bit to sort of try to explain some of these discrepancies between data and reality. I think what Sones and all subsequent angiograms that I did and that all of you have done and that everybody has done is that at 300 micron resolution, this is what we see in terms of coronary artery anatomy. At 30 micron resolution, this is what we see in terms of coronary artery anatomy. Interestingly, this was a study done for an MD thesis only a few years after Sones did the initial coronary angiography. So what you see, obviously, is the standard epicardial coronaries, the big arteries here, but you see this amazing episode or network of capillaries throughout the heart, down to a very small size. And of course, those continue to exist even at resolutions less than 30 microns. So we're not even seeing all of them. So I think we need to reset our concepts of the coronary circulation to include the entire arterial circulation from ostia to microcirculation. And if you look at the amount of resistance to flow that these different levels in the arterial circulation supply, only 5% of resistance of flow comes from the epicardial arteries. All the rest comes from either the prearterials, most from the arterioles, and some from the capillaries. So we focus on these epicardial coronaries for the same reason the drunk looks for his keys under the streetlight. It's because that's where he can see. But there's a lot more going on, and my goal in giving this talk is just to have you consider that the coronary circulation is much vaster than what we see on coronary angiography or coronary CTA. And I think a lot of the outcomes are driven by things that we don't see. And in fact, here's a very clever study that was published in the Canadian Journal of Cardiology in 2015. They looked at the presence of microvascular dysfunction in patients who had persistent angina after they had had a successful PCI. So kind of like the 2/3 of patients I was describing to you in ischemia. And if you look at the coronary flow reserve in the target vessel, you can see that over 50% of those people had coronary flow reserves less than 2.5, which was their definition of microvascular dysfunction. So maybe this is why we do such a poor job at rendering people free of angina after PCI, because we're doing nothing about the microcirculation, including not even telling the patient about it, which I've started doing in my practice. So does the current paradigm apply to the broadest spectrum of stable angina patients? Well, this is a famous study that was published by Manesh Patel from Duke that was published in the New England Journal back in 2010. Huge database, 400,000 patients, grouped according to whether they had atypical symptoms, no symptoms, or classic angina symptoms, and whether they had positive, negative, equivocal, or no non-invasive test. So if you just look at this far panel on the left, patients in the blue bar that had angina, that had an abnormal non-invasive test, 50% of them did not have obstructive disease. Now, if you're telling me that everybody that has an abnormal stress test and doesn't have obstructive disease on cath is a false positive, then we should abandon the whole stress testing enterprise and just flip a coin, because it's really not telling us what we want to know. But in reality, the issue is not that these are false positives, that they are detecting microvascular dysfunction. And if you look at patients that actually present to the hospital with acute chest pain and evaluate them invasively with invasive physiology, you'll see that about half of those have obstructive disease and half of those are classified as having ischemia with non-obstructive coronary arteries. This is a study published in 2019 from the West of Scotland group. And you can see these ANOCA patients are divided between vasospastic angina, microvascular angina, mixed, and only 11%. They couldn't find a reason. Could be altered pain thresholds or something that they didn't test for. But this is the value of invasive testing for people that don't have obstructive coronary disease. Rather than just discharging them and telling them that their chest pain is non-cardiac, if you actually look, you find that 89% of them have a coronary problem that's just not obstructive coronary disease. So I think one of the problems with our approach is that we tend to lump obstructive coronary disease and ANOCA in two separate silos. And we kind of think of obstructive disease as mostly male disease, lots of risk factors, and ANOCA mostly female disease, some risk factors. But in reality, I think that the data tells us that this couldn't be further from the truth. And even the chest pain guidelines, they provide you a separate algorithm for suspected ANOCA. Like, why is this a separate algorithm? Why isn't it all integrated at the time of initial presentation? Why do you have to go through all the testing on the first algorithm, end up in the cath lab, not have any obstructive disease, and then somebody said, oh, let me go back to this 85-page guideline and find out what I'm supposed to do when I suspect ANOCA. I mean, ANOCA should be suspected from the beginning. And again, just to review the sort of mechanisms of myocardial ischemia that can occur separately or can occur together, you can have atherosclerotic disease that leads to large obstructive plaque, reduction in coronary flow reserve, and demand ischemia and angina. This is the acute coronary syndrome pathway, so we'll ignore that. You can have focal vasospasm that causes Prince-Meadows angina. You can have persistent vasospasm that causes myocardial infarction, the so-called MINOCA, or myocardial infarction with non-obstructive coronaries. Or you can have microvascular dysfunction that impairs coronary physiology and blood flow in subjects with risk factors. It contributes to myocardial ischemia and is probably the mechanism responsible for even acute ischemia in Takotsubo. And to further make the point to you that I think that these coronary abnormalities occur together more often than they occur separately. This is a very interesting study from Van de Hoof and his group from the Netherlands, published in Heart in 2014. If you just look at the right side of the graph, so these are 3 groups of patients, all with abnormally low FFRs, right? FFRs that we would consider abnormal, FFRs that we would consider being caused by an ischemia-producing lesion. And then if you divide those into categories based on their HMR, which is an invasive measure of coronary flow reserve. So here's low coronary flow reserve, intermediate coronary flow reserve, and high coronary flow reserve. And then look at the presence of reversible perfusion defects on stress testing. You have to have a high degree of microvascular dysfunction to have a high likelihood of having a reversible perfusion defect. So what this says is that you need a sick microvasculature in the presence of obstructive disease to have an ischemic stress test in most patients. Very important observation that I think this study and this paper is not talked about enough. So I'm going to leave you with lots of unanswered questions. In my mind, questions are: what percentage of angina ischemia patients with obstructive disease have concomitant microvascular dysfunction? What percentage of patients with concomitant obstructive CAD and microvascular dysfunction have their symptoms and outcomes driven by the microvascular dysfunction as opposed to the epicardial lesion? And I will mention one other finding of this study that I mentioned to you that we're doing in Los Angeles with the ischemia trial. Interestingly, patients that have persistent angina, so they undergo PCI, they have persistent angina at either 6 weeks or 12 months, they have significantly increased risk of cardiovascular death and MI than patients that are angina-free. So these are all patients that have the similar revascularizations, but the presence of persistent angina is at least associated with worse outcome. Now, what could be driving that? Well, microvascular disease is one of the things that could be driving it, and we're trying to find ways to actually answer that question more scientifically than hypothetically. So when I started out in cardiology, when I did my interventional cardiology at Cleveland Clinic, I don't think we ever talked about these two entities, but over my career, I sort of initially had the impression that the distribution would be like this, that most people would have obstructive coronary disease alone. Every now and then you'd find an interesting and weird case with vasospasm, and every now and then you'd find an interesting and weird case with microvascular dysfunction. But after Courage, Orbita, ischemia, and some of the other data I presented to you, I really think that the overlap between obstructive coronary disease and microvascular dysfunction is almost total. And that vasospasm is a less common entity, but all 3 of these things can overlap. But these 2 entities overlap, in my view, very commonly. And I hope now that I've planted this seed in your mind, you will think about when you see patients that have been, quote unquote, completely revascularized and still have angina, to think about microvascular dysfunction. So here's how I integrate all of this. I mean, the chest pain guidelines are 85 pages. My mind can't absorb 85 pages worth of algorithms. So this is my algorithm for when somebody comes to my office with stable angina, not known to have coronary disease. I mean, it's a little different if it's an 18-year-old, but assuming an adult with a reasonable pretest probability of coronary disease, I get a coronary CTA, and that tells me a lot of very important things. If it's completely normal, meaning no atherosclerosis, I basically reassure them and go over lifestyle and risk factors if they have any. If they have non-obstructive CAD, I will do tailored OMT for risk factors and maybe some long-acting nitrates or carvedilol or ranolazine or ivabradine or something like that. If they have obstructive disease, I also start with OMT. And if they have left main coronary disease or EF less than 35%, OMT, GDMT, PCI or CABG for left main, but CABG for multivessel disease. And then if the two groups in the middle continue to have symptoms, I will assess them for microvascular dysfunction or spasm in the cath lab, or by using PET scan for the microvascular dysfunction. And the patients that have obstructive disease, I will refer for PCI CABG, and if they continue to have symptoms, then they come over into this treatment approach or diagnostic approach. So to conclude, in my view, stable angina is a symptom of chronic coronary macro and/or microvascular disease. In most cases, ischemia and obstructive CAD are markers for atherosclerotic burden and are not the direct cause of morbidity and mortality, and thus they should not be the targets of therapy. Please, if you only take away 4 words from this talk, it's association is not causation. The history of cardiology is riddled by treatments that we had to eliminate or give up because we associated too strongly association with causation. Thirdly, dichotomization into obstructive CAD and ANOCA is overly simplistic, inefficient, and counterproductive. And finally, stable angina may be successfully treated with an integrated diagnostic and therapeutic approach with limited testing, medications, risk factor control, lifestyle modifications, and in my practice, the vast majority of patients. Thank you. I'm sure there's questions and rebuttal. I'm happy to entertain any.